Please type any questions for presenters in the chat box or email them to donald.moore@vdh.virginia.gov with the subject line LHD call question. Today's agenda will have the VEST update, we'll have a vaccination unit update, a testing update, modeling update. We will actually not have the pH and other ops update, but it will be replaced by the Ebola update. The pH and other ops, their slide set will be at the end after the questions for your review, but it will not be presented today. To go ahead and get things started off, we'll have the VEST update with Susie Silverstein. Susie, if you're on the call, please begin.
Great, thank you, James. And good morning, everybody. Could we go to the next slide, please? So I'm going to begin with just an update. It's a follow-up to an email that was sent out by Shamira last night. For any districts that are requesting vaccinators or any staff that are going to require COV access, please do not put those requests in WebEOC. Work directly with your business managers to get those positions filled through the contract agencies. What's happening is it's getting hung up in WebEOC and it takes about a week to go through the process, and they're going right back to the business managers to process through the contracts anyhow, and it's slowing down the process for you. If any districts have problems with the contractors, you should contact Roxanne Earhart and OPGS, and she will be able to interface that for you. So moving on to the next slide, I want to provide everybody with an update on the training plan. We updated the training plan this morning, and just a brief overview of what was changed. We've added the CDC training and skills checklist for the Johnson & Johnson vaccine. We've made changes to the CPR requirements. They're still required for VDH employees, but we've suspended them for volunteers. It seemed to be a bottleneck in the process that was preventing volunteers from getting their training. So we have suspended that requirement, and we're looking to get people with CPR in the sites a different way. The turnkey operators, we're asking them to have people trained in CPR, and we're working with the Guard to get the Guard members trained in CPR. So we make sure we meet that requirement, but we're just not putting it on the volunteers anymore. We made changes to the multi-dose vial course. We updated doses from 5 to 6 for the Pfizer vaccine, and we included a reporting of wasted doses in that course. We've also made changes to the skills checklist. We reflected the change in CPR, adding reporting of wasted doses. We added language regarding prevention of needle stick injuries. We've had quite a few just this week with people not knowing how to use the safety. And we also added changes to the Pfizer storage, that it can be stored in a conventional freezer for up to 2 months. Next slide, please. We have several other plans in the works, and we're hoping to get these changes into the training plan by the end of next week. You've all probably heard about the HB 2333, which is the bill that allows for community vaccinators, and we'll have that training plan posted. It's very similar to the just-in-time training plan that is currently in the training plan for VDH employees, but we'll clarify what falls under HB 2333 and the PrEP Act. They each have different requirements based on how many years you've been with an expired license. The J&J training materials are just posted right now. CDC is working on an actual course that'll include an audio portion, and that should be done hopefully by the end of this week so we can get it updated in the plan next week. We're going to include information on the safety needles in the multi-dose vial course. The course that we currently call the EMS training, which is the course on how to give an intramuscular injection, we're revamping that course. We're going to take out some of the information that's nice to have and just need so we can get it down to about 20 minutes because it's currently 40. We are adding sessions And we're trying to add sessions all over the state to help get the skills checklist completed for the volunteers. Right now, we know that's another bottleneck that we're trying to address. We have a training course that should be done next week as well for all the volunteers and contractors that'll be working the community vaccination sites, which is just an overview course, what to expect, information on HIPAA, information on airborne precautions, and we're putting it all into one orientation that they could take before they begin to work in the community vaccination sites. And then we're also continuing our work on the micro learnings. We have one that's posted right now on post-vaccine observation areas, and we'll be adding one on PPE for vaccinating and adding one on using safety needles. So those are my updates now. If you have any questions, go ahead and put them in the chat, and I will put the link to the training plan in the chat as well. Thanks so much. And James, back to you.
Thank you, Susie. Next up, we're going to have the vaccination update. Marshall, are you on the call?
I am. Good morning, everybody, and happy Friday. If we could move to the next slide, I will go over today's agenda. We have some vaccine updates for you with the J&J vaccine, as well as updates for the vaccine campaign that touch on pre-registration, provider reminders, the Federal Retail Pharmacy Partnership, and the Department of Corrections, and then some additional updates on VANS and PrepMod. So if we could go to the next slide, some updates. Everybody is probably well aware of this, but very exciting that the Johnson & Johnson or Janssen vaccine did receive FDA, EUA, and ACIP recommendation this weekend. It's now authorized and recommended for adults 18 and older. This vaccine is a single dose. It uses a virus to deliver the genetic material that codes for the SARS-CoV-2 spike protein. And once the cells receive that information, much like the Moderna vaccine, they generate that spike protein and it stimulates an immune response. This vaccine is only one dose, however, which does have quite a bit of an advantage to us, and we'll talk about that in just a minute. The initial allocation to the United States will be about 2 million doses, and we're going to get about 69,000 allocated to us at VDH. There are some other doses to pharmacies and other folks, I think, that might change that total number. But that's roughly ballpark what we're going to be having come in the door that VDH will be responsible for. Global studies found it was 66% effective against moderate to severe disease, with higher effectiveness estimates for severe disease, hospitalization, and death. There's been a lot of press about comparing it to the other two vaccines out there, but it's important to remember that these vaccine effectiveness estimates cannot be compared, quote unquote, head to head, because the study endpoints were different and the timing of these studies were different. So it is a very effective vaccine. We're excited that we are going to be getting this. And if we go to the next slide, I think on some of the potential advantages of a single dose vaccine, which is really for mass vaccination events. The J&J vaccine is perfect because, again, it's strong efficacy. Our initial allocation amount, we're getting quite a bit. That single dose regimen, and then of course it doesn't have to be held at those ultra cold temperatures. It has a lot more flexibility in terms of storage, even at just refrigerator temperatures. Our key messaging as we're getting this vaccine and beginning to administer it is that it has proven to protect against serious illness, hospitalization, and death. It's only one dose, so that's great for people that don't like needles or populations where it might be hard to get them back for a second dose. Our messaging is that ultimately the best vaccine for you is going to be the one that's available first. And we're really trying to message that. We don't want people necessarily shopping, quote unquote, for vaccines because we want vaccines in arms. And again, we are pushing the call center vaccinate.virginia.gov for pre-registration, and then 877-VAX-IN-VA for additional information and assistance with pre-registration. If we go to the next slide, I do have some updates for our other vaccine candidates. Pfizer, you can see, has now come out and said that it's possible to keep it out of ultra cold temperatures for up to 2 weeks. And then, of course, it can warm up for that 2 to 8 degrees Celsius storage for 120 hours. So that's roughly refrigerator temperature. It's not going to change how the Pfizer vaccine is shipped, but it's just going to make it easier for you all to store Pfizer vaccine. If you were to receive Pfizer vaccine, you wouldn't need an ultra cold freezer as long as you were able to use that vaccine within a couple weeks, plus that 120 hours or 5 days when it would sit at fridge temperature. It's important to note that if it does come up to that freezer temperature out of ultra cold, that counts against the total cumulative time. You'll see there under additional background, that fourth bullet. And there's a link in the slides that has more information about this if you need it. If we go to the next slide, information on Moderna. Moderna is, as they're ramping up production, to use some different lots of vials. Some of the vials might have a slightly different tint, and that greenish tint may actually fade over time to more of a yellowish tint. So just because the vials look different doesn't mean the vaccine is bad. It may just be a different type of vial. However, you always need to check your vaccine. You know, you want to make sure that there aren't unnecessary particles in there, that it meets the description of the vaccine that's on the FDA usage paperwork. So just pay attention that vials may look a little different, but that doesn't necessarily mean that the vaccine is expired or can't be used. If we go to the next slide, we'll shift now and talk a little bit about pre-registration and the call center. Again, that web-based pre-registration tool is up and running and continuing to collect pre-registration data. Most of the local health district data is now integrated into that database, and we have been working, Carlos Rivero and his data team have been working very hard to add in additional filters. So the idea is that you're going to be able to go in and find people based on their age, their priority group, their occupation, their vaccination history, several different variables, which we hope will be beneficial to you. But please reach out if you do have more questions about that, and we're certainly willing to support you all as needed. The availability, to verify your pre-registration is once again live. That's working better, and it's not case sensitive like it was before. And you actually have the ability to go in and edit your pre-registration now as well. So we are going to be messaging some people where, you know, we have a name and a phone number, but not much else. And really trying to make sure that people are aware they can update this information. And the more information that we have in their pre-registration file, the greater likelihood it is that we'll be able to identify a potential priority group that they fit into and pull them down for vaccination. If we go to the next slide, some provider reminders. One that's not on this slide, but I've been asked that as you all plan clinics, please be sure that you're using that red cap form for local health district vaccine events. It's very important that we have awareness so that we can give it over to VDEM and up to the governor's office and the secretary for where our vaccine events are occurring. Also, please remember to report your daily inventory and remind your providers that you're partnering with to report that daily inventory into Vaccine Finder. Report those daily doses administered into VIS if you don't have a way to get them there through VAMS, PrepMod, or an electronic health record. And remember to report any redistribution daily. This helps us get the most accurate data in our hands so that we can make allocation decisions and really know where the vaccine is going. If we go to the next slide now, some updates on the long-term care facility vaccination program. Walgreens has completed first and second clinics in all skilled and assisted living facilities in Virginia, and CVS has completed 100% of their first and second dose clinics in skilled nursing, 100% of their first dose clinics in long-term care, or assisted living facilities, and 97% of their second dose clinics in assisted living facilities. So making a lot of progress there. Third and final clinics are underway, and they will continue through the end of March. And a combined 226,284 doses have been administered to residents of these long-term care facilities. Now, if we go to the next slide, obviously there are going to be instances where the long-term care facilities do need some follow-up for residents that weren't there when those final vaccines were given in that third round. And so the long-term care facility and pharmacy program in the vaccine unit has built this bridge program to really support long-term care facilities with their ongoing needs. So not just those few residents, but really to build in an infrastructure once these CVS and Walgreens up for long-term care facility residents to continue to be vaccinated. And so it has two strategies. Again, one, connecting those long-term care facilities to vaccinators, and then also trying to get the standard pharmacy infrastructure kind of back to helping with this federal retail pharmacy partnership program as quickly as possible. So we'll dig into the strategy one on the next slide. To meet the ongoing need, you'll see that there's the MHA Pharmacy Network, and that represents 5 pharmacy groups in Virginia that can cover almost all of the Commonwealth. They're going to be kind of serving one pharmacy as the hub, and then other partners will redistribute that vaccine for ongoing needs, and other state pharmacy partners have also indicated their willingness to assist. So we are connecting these long-term care facilities to pharmacies that are able to keep in touch with them, keep those vaccines going into arms. And if we go to the next slide, we'll look at the recovery of the pharmacy infrastructure. Again, many of the facilities are served by pharmacies that provide medications, so can we connect them there? The current paradigm really would require each facility to be enrolled as a vaccine provider. That has its own issues, so we're really looking about how we can use the existing infrastructure to help manage COVID-19 vaccination. And it's under evaluation right now, so more to come on that. But long story short with this, we want you all to know that even though CVS and Walgreens are finishing up with their 3 vaccine clinics, that we are working to ensure a continuous supply and availability of vaccines to pharmacies. Wrapping it up on the pharmacies on the next slide, the federal retail pharmacy program that you can see there continues to expand. The takeaway for this slide, or from the slide rather, is just the sheer amount of doses and the fact that we're continuing to add sites across the state. So we're very excited about that. And on the next slide, we'll talk about doses for recently released individuals. VDH has been working with the Department of Corrections to coordinate efforts for these inmates who might have gotten their first dose while incarcerated, but they were released prior to receiving their second dose. And so we will get a weekly summary of these individuals and share that with you at the local health districts in an attempt to try to contact these individuals and make arrangements to get them their second dose. We'd like you all to do your due diligence. We know that some of these individuals might be hard to get a hold of or might be hesitant to come in to a local health department, but please, as you're capable, provide those vaccines to individuals. And lastly today, if we go to the next slide, some updates on VAMS. VAMS 2.1 was released this weekend and does have some enhancements. The jurisdiction call center managers can now edit and remove contact center agents and managers. This would be for assisted scheduling for appointments, and some health districts are using this in VAMS. And enhanced ability to export recipients from third-party clinics. Standard and mobile clinics have more flexibility to control appointment bookings, and they can also create messages that are sent after scheduling an appointment. Now, unfortunately, once you add them in and they get that email that they're eligible to go register for an appointment, you can't really put a lot of text in that email and customize it. But once they create an appointment, you do have the ability to customize that text. And so you could say, be sure to park here, or don't forget to bring your ID, those sorts of things, or a question, if you have it, to contact a certain contact, for instance. And then finally, there's a little bit of additional clarity when you're setting up clinics. You're going to see some red X's when you're setting up clinics, and those will turn green as you're completing the information that needs to be in the VAM system in order to let a clinic go live for scheduling. So we hope that that will help you a little bit to know that you've got all your ducks in a row and that that clinic really is live and ready for scheduling. And then finally, with that assisted registration, if you provide contact information during that, so you weren't in the system before, you will now receive notifications. And finally today, we'll move on to the PrepMod update, and we can skip that title slide and get right into our timeline here. You can see that we are well past our deployment and onboarding for PrepMod. All districts are now onboarded, and we'd like you all to continue trying to use PrepMod, but we do understand that there are still outstanding issues in PrepMod, and so districts should use whatever is going to work for them. If we go to the next slide, you can see that there are some onboard and training metrics here, just to show you that trainings are being completed at a pretty good clip. And we do see, 394, the text on this slide is a little bit small, 594 upcoming clinics, 29 clinics completed. So this system has worked really well for people, and we do hope that with some of the additional enhancements, the system will work even better and we can begin to really shift to that system statewide. If we go to the next slide, you'll see some information there just about PrepMod support. There are all users office hours that take place pretty frequently, and you can see the different times there, and there are some courses that have been put into Train. So if you want to go into Train, you can look at those course numbers and get some additional information about the PrepMod system. And then with PrepMod on the next slide, if we could go to just a few housekeeping items here. Remember, save and submit is very important to make sure that information is transmitted to this. Scheduling second doses while people are in that 15-minute waiting period is preferred. I have seen that in clinics, and we thank you for taking advantage of that 15-minute waiting period. Please make sure that you're using the right viz codes and that you're checking your lot numbers. And if you have issues with that, please contact the folks that have their email addresses here on the screen, Nitin, Dana, and Sue. And then it's also a good idea to print the registration list for the clinic at the beginning, just in case you have internet connectivity issues, or we have had a couple instances this week where PrepMod went down for maybe a minute or two and then came back up, but it did interrupt workflow. It's always good to have a paper backup just in case. And on my final slide, we will talk about the new features coming to PrepMod, the appointment selection hold feature. This basically allows you to pick an appointment, and then it gives you 15 minutes to go through the process of registering for an appointment, and the experience has been improved a little bit as well. And you can see some other things there about access levels, and of course the J&J vaccine has been added in. We have tested the individual clinic registration link and are getting closer, but are not there yet. We continue to push PrepMod, but we have discussed other systems that we can use to work with you all to avoid situations where you have people sharing the link and creating issues at clinics. And then finally, on our next slide, thank you as always. I forgot to remove the stick around for our fireside chat. That happens after our Wednesday calls. I did want to put up a picture of Dolly Parton. She did receive her vaccine this week. And if you're a fan of Dolly Parton, I would encourage you to look up her vaccination experience. She did a little ditty that is a riff on Jolene, and I think you'll find it quite amusing. At least I did. Thank you all so much. Have a wonderful weekend, and back to you, James.
Thank you, Marshall. Next up, we have the testing update with Susie Trotter. Susie, are you on the call?
Yes, I am. Can you hear me?
We can. Please go ahead.
Fantastic. Thank you. Good afternoon, everybody. Going to go over just a little bit of our testing metrics, what it looks like now, a little bit about our expansion with our public-private partnerships, some early discussion about our pilot K through 12 screening testing, and then the good news about our antigen expiration dates. Next slide, please. So as usual, we like to show the schematic of what has happened over the past week. This is actually across the month of February. The green on the left, you can see, are the daily antigen tests stacked on top of the daily PCR tests. And we did a healthy average in the middle around the 25,000. We are seeing a decrease. If you look on the right-hand side, we had 627 plus thousand PCR, 300,000 antigen for a total of 927, which is about a 30% decrease of testing from the month of January into the month of February. So we do see the orange PCR positivity rate going down, which is good, but we do have a concerning decrease in the number of PCR tests being executed within the Commonwealth. Next slide. This shows a little bit more of a pictorial of what's occurring as we expected or knew. The conflicting priorities. Certainly understand the vaccination priorities to get up to herd immunity, but there is only so much staff to do so much work. So this is just representing where it did occur. As we knew, as LHDs were getting pulled into the vaccination front, that community testing events would decrease in the numbers. So you can see we're kind of reflecting what it looked like back in Thanksgiving, where there are less community testing events. Certainly appreciate those districts that have plans in place and continued. I know it's a strain. We can't thank you enough for standing up those community testing events really across the Commonwealth. It's still just as important to get testing done so we get a good representation of what our public health status looks like in the Commonwealth, including the variant testing. Next slide, please. In addition to the decrease in the number of community testing events, like we said, as expected, this pictorial will show you then actually the turnout, which is a whole nother aspect of what we're experiencing with testing, not only in the Commonwealth, but in the nation. So if you look at this slide, this was across really February 15th up until March 2nd. So those that had community testing events, the ability to stand them up, as you all well know, it still takes just amount of effort to stand up an event as it does to stand down and then actually have folks turn out. The dark blue will show you the numbers of folks that actually came to a community testing event. Each of these had an expected, well, most of them had expected turnout of 200, which is what we were running in the fall when we were at our best. A couple of those were expected 150. We actually had our first zero show at Clifton Forge on March 2nd. So as a Commonwealth within our unified command and our best, and working with our communications and our ad agency, we are looking at communications, messaging to see if we can't address this behavioral change that we're seeing. So again, please continue to set up the community testing events. We're working on the back end to work with communication and see if folks won't come out more. I know that's a tough battle because we've got, you know, the vaccination concepts as well. If they're vaccinated, why do they still need tested? However, as you all well know, we are looking at potential spikes. We'll hear from modeling later, but we need to be ready, and we are prepared to continue to do or stand up more testing events as needed, but just showing the picture of where we are now. Next slide. The good news is, as our goal has been, is to build up testing out in our public and private sectors. So we have seen a growth. We added 6 more this last week of more testing locations. So the left will show you from October up until February 26th. The increase of testing sites, and the pie chart on the right hand side will really show you where that breakdown is. You can see that 41% in the gray is pharmacies. So they are multitasking, not only providing vaccinations, also providing COVID-19 testing in their pharmacies. And then the next representative is urgent care. They have just been a powerhouse for our COVID-19 testing, and we've been able to supply them with our antigen Buy Next Now cards as well. So that's been a great growth in the area, and we will continue to work on building out testing out in the communities because as we go along, we certainly want to preserve the health department for, you know, the at-risk and the safety net. Next slide. So speaking of which, we had a press release this last week that 7 additional Walgreens have opened. And again, this is utilizing the free Abbott Buy Next Now rapid antigen testing. And these locations were selected as well within using our equity and our metrics as far as areas that have low access to testing locations. This is going to round out our 25 or 26, where those were our original metrics on where to stand up testing locations. Each of these can do 50 tests a day. It is free. There's an online registration, but if you have difficulty with registration, you can call the Walgreens. So as far and wide as you can share this with your local partners, your school districts, we appreciate it. We have done the same, but as you know, we are inundated with information. So this is great news for this week. The next slide will actually show you the comprehensive look of all the Walgreens that we have partnered with, utilizing our HHS resources, our Buy Next Now antigen cards. And again, Walgreens is with us and developed a very nice program where they will do its testing every single day. 50 slots are available. And we will continue this throughout into the summer, and it is part of our ELCED budget to be sure that this sustains. The next level of Walgreens, we are asking for those stores that have high throughput. So now that we've addressed some equity, looking at access and locations so that we have testing available within at least a 50-mile radius. Our goal is 25-mile radius of 95% of the population. This is one sector. The next part is now to increase capacity in the high throughput Walgreens stores. So those that have the highest traffic, we're seeing those appointments fill up fast. So we're going to layer more, as well as Top priority is looking in the eastern region that has not been able to stand up a community testing event for some time. So our request through Walgreens is to focus in on the eastern region first, and then continue with large throughput for our next phase. Next slide. And this is the bulleted or the polka dot map where you can see the overlay, the 7-day average daily new cases per 100,000 with our testing locations. So the grayed out map will show you the color gradient as far as the number of cases, again, 7 days per 100,000. And then in addition to that, you can look to the testing locations. And of course, you can see clusters at Metropolitan because this is all testing, drive-through up testing, federally qualified healthcare center, free clinics, hospitals, doctors, pharmacies, urgent cares, et cetera. So this is part of the metrics that we utilize as far as where we want to focus continued growth for where testing locations are available. Next slide. This is the snapshot for turnaround testing time that we do like to share. The left-hand side where you can see the pie chart really shows where the bulk of the performing of testing occurs. You know, over half is commercial, 22% hospital, and then our public health sector is 2%, which this is the goal. What we want to see is the continued growth out into the community for those that can get access and get there and get testing. We want that built up, and then preserve our resources in public health for those underinsured and unable to access. The turnaround time, testing turnaround time did pop up a little bit, but overall across all lab types, it's down to 0.91, and the increase was subtle in the commercial, although concerning, and we will keep our eye on it to look at whether it's supplies or resources, slightly up at 1.5. Next slide, please. So a little bit about finalizing the K through 12 testing guidance. Absolutely appreciate the opportunity to speak with the health directors on Thursday to get input and feedback as far as what you all are seeing in your communities and what any of the schools have asked for. What we're looking at overarching, and we'll work on it this afternoon and then present again to the schools next week, is again, this is a voluntary pilot program. The schools may opt in. And as you all know, this is an additional layer of protection. It is not a standalone. Mitigation needs to be primary and strictly paid attention to. The 5 key mitigation strategies outlined in the document already. So what we're looking at is to provide schools with the necessary tools, which would be the Buy Next Now cards, point of care testing for school staff, with the goal of testing, of course, symptomatic staff, but as well as asymptomatic staff on a routine basis with confirmed COVID-19 exposure. Pilot time frame April 1st through June 30th. This is the supply that we will offer up, and then work with the schools as far as those that are able to implement it and are interested. And we will work with them with the other factors that need to be in place, as you all well know, and we've discussed many times before. On the next slide is the process schematic on how to implement testing. And on the left-hand side, again, is, you know, developing the plan, who's the staff, who's the team, who's going to collect the samples, who's going to be responsible for what, determining, you know, the plan, the testing, you know, cadence, and then get consent. The obtaining the order, we are working on as far as getting a standing order for K through 12. A big part of that was to have the rest of the process or the protocol laid out, which we've gotten further since we were before. So policy is working on a standing order for schools. And then where we as a state are able to assist is help them through some of this processing. The CLIA waiver, we will certainly provide the Buy Next Now cards. We've got the ability to get them to get access to the training. then as well as how to test in the schools, and then get them connected with VDH for the portal. And then our contact tracers and contact investigators, of course, can work with the positives, and we'll be working with the schools as far as how to report out the negatives and the testing for those that were tested. Of course, if it's staff, they'll know right away, but then there has to be a process within the schools to know what to do with that. So that's where we are. Appreciate again your time to work that through us, and we will keep you updated as far as what the final document looks like next week. And then last but not least, great news, our Binax Now COVID-19 antigen cards, the expiration date was extended. Hopefully you all got the information on that as well. Be sure to look at your lot numbers, and those that were at the 6-month expiration have been extended to 9 months. So it's important to check if that lot number on the box of 40 cards that you have, and go ahead and document and write the new expiration date if applicable. If you did not receive that email, please reach out to antigeninfo@vdh.virginia.gov and we'll get that to you. But that does provide an extension and ability to use these Binax Now cards further. And then the final two we were waiting for, we have as well. And additionally, if you need more, we have done some outreach and we've gotten some great uptick of requests, partially due to our Deloitte staff doing a one-on-one voice call with some stakeholders, and the other part is the extension of the card. So if you know of anyone or need any more, there is the link to order more Binax Now cards. I believe the next slide will leave you with the as well, antigen Binax Now cards as well. The last slide then is the slide we used last week to update you for who your regional testing liaison contact person is. So I know it's a repeat, but I want to go ahead and put it in the slide set for you to have for future reference. And I'll take questions in the chat.
Thank you, Susie. Next up is the modeling update with Chelsea Kanan. Chelsea, are you on the call?
I am. Can you hear me?
You can. I can. Go. Please go ahead.
Okay, great. Thank you. Can you move on to the next slide, please? So the model background hasn't changed since prior weeks. UVA is still using an adaptive fitting approach that takes into account current trends and improves with more data every week. Next slide, please. Looking nationally, there are no states in the country that are in a surge trajectory this week. All states are either declining or in a plateau. In terms of reproduction number, a few states kind of stand out. Iowa has a particularly low reproduction number. The area under the curve is shaded in a darker blue, showing that their reproduction number is under 0.5. Arkansas has a darker red shading under their curve, showing a higher reproduction number of over 1.5. Virginia is in a declining scenario, and the shading there is light blue, showing a reproduction number of less than 0.9. Next slide. So a little closer to home, we can see that a lot of the neighboring states have shown increases from last week in caseloads. The declines that we saw last week have stalled in Tennessee, DC, West Virginia, and Maryland. Only North Carolina and Kentucky are currently showing declines in their caseload compared to last week, but they do have very high caseloads of higher than 20 cases per 100,000. You can move on to the next slide. And across Virginia, case rates are declining again. 65% of counties now have case rates under 20 cases per 100,000, and 14% of counties have case rates of under 10 per 100,000. This is an improvement over last week. Last week, I think about half of the counties had case rates under 20. All right, next slide, please. So this slide shows the point prevalence by zip code, and this is also declining. Charlottesville, again, has a fairly high point prevalence as a result of the outbreak at UVA, but this is down pretty markedly compared to last week. You can see there are a few pockets of zip codes that have higher case rates, but generally they're fairly low across the state. Next slide, please. So this week, the health districts are looking good. There is not a single health district in either a surge trajectory or a slow growth trajectory. They're all either declining or plateau. In fact, most of them are declining. There are only 2 in a plateau trajectory, so that's looking good. Next slide, please. So the effective reproduction number is up a little bit compared to last week, but it's still good. It's 0.8 statewide. Nearly all of the districts increased a little bit compared to last week, with the exception of the Northwest, which went down quite a bit. The decrease is probably a result of that outbreak at the UVA campus getting to be under control this week. So their reproductive number went down a little bit, actually quite a bit, whereas across the rest of the state, all of the districts increased just a little. Next slide, please. Test positivity continues to decline, as we saw from some of the earlier presentations, and the number of days from symptom onset to diagnosis is also down a little, although it's been fairly stable over the last month or so. Next slide, please. So the risks that we've been looking at, the key ones being seasonality, holiday travel, and variants, are fairly consistent. We're now into March, so the impact that we would expect to see from seasonality is decreasing a little bit. We're also starting to see more of an uptick in a favorable shift from the vaccine, so risks we would expect to begin to diminish even more due to the increasing prevalence of the vaccine. And on the flip side, variants are also starting to increase, which is going to present a slightly larger risk beginning around now and into the coming months. Next slide, please. So vaccine acceptance is relatively stable. It looks like it's been declining a little bit, but again, the scale on this graph suggests that there might have been more of a decline than there truly was. We've been hovering around about 74% of Virginians who would answer yes, or would answer that they would probably or definitely get a vaccine to them if it was offered to them today. Next slide. So we're now at 8% of Virginians who are fully vaccinated. 7% have received their first shot. And we're still at a point where vaccine supply is the limiting factor. Demand doesn't yet exceed supply, but we do expect in the next month or two that vaccine supply might become less of a constraint, and we would need to focus our efforts on trying to improve demand. Next slide. Great, so now we'll shift into the UVA model. There really haven't been very many changes to the model methodology this week, so we can go on to the next slide. As with prior weeks, each of the model scenarios has a variant scenario paired with it, which assumes that the B117 variant will begin to predominate late March, and that it will be about 40% more transmissible. Next slide. So the vaccine scenario is also currently based on the 2-dose vaccines, which are Pfizer and Moderna. The Johnson & Johnson vaccine will be incorporated into a future iteration of the model as it begins to roll out, and vaccine hesitancy will also be incorporated into a future version of the model. The figures on the right of this slide show that vaccination rates are increasing. That's the figure down at the bottom, statewide, and also that vaccination rates in Virginia are higher than that of the country overall. Virginia is that red line. The country overall is a black line. Next slide. Here we can see again that vaccination rates are increasing in Virginia. So rates are up to about almost 300 first doses per 100,000 people per day, which is up a little bit from last week. And this slide also points out that the vaccination rates are taken into account on a county level in the model. Next slide, please. Here's a summary of the 6 modeling scenarios that are presented. The adaptive scenario is essentially the current course, showing what might be projected if things continue as they have been. There is the fatigued control scenario and then the best past scenario. Those are sort of a best case, worst case scenario for what we might expect to see going forward if things are revert to what we had seen in the worst case situation we've seen so far, or the best case situation we've seen in the past. And those 3 scenarios are all paired with a variant scenario in which we would expect transmission to increase as a result of the variants that begin to become more prevalent. Next slide, please. Here are the results of the adaptive scenario. So this is the current course. And along the current course, I'd expect that we have already passed the peak, which was over 40,000 weekly cases at the end of January. So we don't expect there to be another surge. We're currently declining. The rate right now at the beginning of March is a little bit higher than it was during the peaks that we saw last summer, but we are in a declining scenario with no additional surge projected. Next slide. This shows how the model has performed, the adaptive model has performed compared to actual case rates. And the yellow shading shows that generally the observed cases are fairly consistent with what the model projected. So across the state, the model has been doing fairly well. There are a few spots where the model projected either fewer or more cases than expected. Along the kind of the central to western region, there were some fewer cases than expected counties, and then along the western border of the state, we saw that there were some more cases than expected. Next slide, please. The fatigue control scenario does show that we would expect to see another peak in cases later this summer, though the peak would not be as high as the one we have just experienced in January, and it would be higher than the peak that we experienced last summer. Next slide, please. Now what's a little bit more concerning is looking at the fatigue control scenario paired with variant B117, resulting in increased transmission. So under this scenario, we would expect to see a considerably larger peak in the July timeframe with over 100,000 weekly cases. This is considerably higher than the peak we experienced last summer, and it's even higher than the one we just saw in January by about 2.5 times. So we would hope to avoid this scenario. The variant is something we don't have as much control over, but the fatigued aspect of the situation, something we would have to try to encourage. So really emphasizing the importance of maintaining social distance, wearing a mask, and then getting vaccinated when eligible. All right, next slide. This summarizes the 6 scenarios. The projections, again, are showing that the current course, as well as all of the other scenarios, aside from the fatigued variant scenario, project that we have already passed the peak, with the peak having occurred the week ending January 24th at 40,000 weekly cases. The fatigued variant scenario projects that we'll reach another peak the week ending July 11th at over 100,000 weekly cases. Next slide. So the good news is, even with this fatigued control and variant scenario, we do not expect hospitals to exceed their capacity anytime in the near future. Next slide, please. Here again are links to various information sources, and I believe that's the last slide, so I'll be happy to take any questions in the chat. Thank you.
Thank you, Chelsea. Next, we're going to have an update on the Ebola outbreaks in Africa and traveler monitoring in Virginia.
Hey, James, this is Katie. Can you hear me?
I can. Please go ahead, Katie.
Great, thank you. Good morning, everyone. This is Katie Kirkchen. I'll be providing this Ebola update on behalf of the team. Thank you. This slide summarizes the key facts about Ebola. Ebola virus can spread through direct contact with blood or body fluids of a person or animal who is sick with Ebola, or objects that have been contaminated with the virus, for example, needles or syringes. It can also be spread via semen from a man who has recovered from Ebola. Those at highest risk of getting Ebola are family members and friends in close contact with Ebola patients, and healthcare workers who do not use proper infection control while caring for patients. The signs and symptoms, particularly the initial symptoms, are nonspecific and include fever, severe headache, muscle pain, weakness, fatigue, diarrhea, vomiting, abdominal pain, and unexplained bleeding or bruising. These symptoms can appear anywhere from 2 to 21 days after exposure to the virus, but the average is about 8 to 10 days. A person is not infectious until symptoms start. FDA has approved a vaccine called Ervebo in December 2019, and this is recommended for certain adults who are at risk of being exposed to Ebola virus, for example, outbreak responders, laboratorians or other staff working in special biosafety level 4 facilities, and healthcare personnel working at federally designated Ebola treatment centers. In 2020, FDA approved 2 monoclonal antibody treatments for Ebola caused by the Zaire Ebola virus strain in adults and children. Next slide, please. There are 2 outbreaks of Ebola going on right now in Africa. The first is in the Democratic Republic of the Congo, or DRC, which is located in Central Africa, in a province called North Kivu, which is shown in orange in this map. The outbreak was announced on February 7th, and as of March 1st, there were 8 cases in the affected province. The same area had an outbreak back in 2018 to 20. That was the largest outbreak in DRC's history. Sequencing of samples from the current outbreak suggests that the cases are linked to cases from the previous outbreak and likely caused by a persistent infection in the survivor that led to either a relapse or sexual transmission of the virus. Next slide, please. The second outbreak is in Guinea, which is located in West Africa, and a rural prefecture in the southern part of the country, highlighted in orange on the map. The outbreak was announced on February 14th, and as of March 1st, there were 17 cases. These are the first cases since the 2014-2016 outbreak, and sequencing is underway to determine if the current outbreak is the result of a new introduction or linked to cases from the previous outbreak. Next slide, please. The risk of Ebola being introduced into the United States is considered to be low for a variety of reasons. Both outbreaks are confined to relatively remote areas. Both are small in size. And to date, all cases have been epi-linked, so there does not appear to be widespread community transmission. Also, travel is down because of COVID-19. CDC had previously issued level 4 travel warnings for COVID-19, and on February 24th, they issued travel 3 warnings for Ebola to avoid all non-essential travel to those countries. The number of travelers entering the U.S. from these countries is low, with about 60 travelers per day. These countries are reportedly conducting exit screening, but we haven't seen or heard a lot of details about that. And lastly, there are no direct flights from these areas to the U.S. Next slide, please. On March 2nd, CDC issued an order that was effective on March 4th at 11:59 p.m. that requires airlines to collect and transmit contact information to CDC for public health follow-up for all passengers boarding a flight to the United States who were in the DRC or Guinea within the 21 days before their arrival in the U.S. The Customs and Border Protection, or CBP, also issued an order to direct all aircraft carrying people who were in these countries in the past 21 days to one of 6 airports, U.S. airports. Those are Washington Dulles, New York's JFK, Atlanta Hartsfield-Jackson, Newark International, Chicago O'Hare, and Los Angeles International Airport. Now, these airports were chosen because 96% of travelers arriving from these countries already enter the U.S. through those airports. Dulles receives the second highest number of travelers among these 6 airports at about 12 travelers per day, and they may not be the final destination for all passengers. Next slide, please. When arriving at Dulles, travelers will be visually inspected for signs and symptoms of illness. Airport staff are not measuring temperatures or conducting interviews to assess the traveler's risk of Ebola exposure, like they did previously. Assuming the person does not appear ill and there are no reports of illness from the airlines, the person will be given a travel health information card, which is shown here, that describes how Ebola spreads, the importance of monitoring their health for 21 days, and to call a doctor if they develop symptoms. Unlike during the 2014-2016 outbreak, there will not be, these travelers will not be receiving a care kit, thermometer, or a phone. If the traveler appears ill, then he or she will be referred for medical evaluation. And if off-site evaluation is indicated, then the Dulles quarantine station staff will call VDH for consultation. Next slide, please. In terms of Virginia's monitoring of these travelers, this starts officially today. CDC plans to send VDH a list of travelers and their contact information. Even though today is the official day, it's likely to be 1 or 2 days before we receive our first list. VDH will send that information to the health districts conducting monitoring. The health department will call that person to conduct an initial interview where they introduce themselves, assess the risk of possible exposures, describe the monitoring program and how to monitor for symptoms, provide health education on what to do if he or she develops symptoms, and that's immediately isolate and contact the health department, and answer any questions. For the remainder of the monitoring period, VDH is initiating a REDCap monitoring project where people can submit a health update by email or text. We're also exploring other options to include enhancements to SARA Alert for monitoring. The frequency of these automated check-ins will likely depend on the findings from the exposure risk assessment, but could be minimal, like 2 additional check-ins at the middle and end of the 21-day monitoring period, or potentially daily. If the person reports symptoms via email or text, then the health department will call that person to learn more about what's happening and refer them to a healthcare facility for evaluation. They'll also contact that healthcare facility and coordinate with them about the situation. Monitoring is expected to occur 7 days a week, meaning that if a list of travelers is received over the weekend, then the initial interview for that risk assessment would need to occur. Next slide, please. This slide summarizes our recommendations for the travelers under public health monitoring, and I want to stress that this is subject to change because we are waiting on some CDC guidance and expect to receive that very soon, likely this weekend. We're proposing to get travelers who will be under public health monitoring to sign a traveler agreement. Public health monitoring would occur for 21 days after departing the country, and if the person develops symptoms, he or she should immediately isolate and call VDH. Per our current COVID-19 recommendations for international travelers, all travelers would be recommended to stay home or quarantine for 7 days after travel. Assuming the person does not have any high-risk exposures, then there would be no further movement restrictions except to notify the health department in advance of any travel more than 50 miles from their residence and ensure monitoring can continue. If the person reports a high-risk exposure, then we would recommend quarantine for the entire monitoring period. Next slide, please. CDC defines a person under investigation as someone who has both signs or symptoms and an epi risk factor. Symptoms include temperature or subjective fever or other symptoms like headache, severe headache, fatigue, muscle pain, vomiting or diarrhea, abdominal pain, or unexplained hemorrhage. And the epi risk factor needs to occur within the 21 days before onset. If a PUI is identified, then VDH will contact CDC to discuss the situation. And CDC's approval is required for any Ebola virus testing at DCLS. Next slide, please. In terms of testing, DCLS will provide 24/7 Ebola testing for all CDC-approved PUIs using their real-time PCR test. An emergency courier service will be provided to transport specimens to DCLS 24/7. The first tier of testing will be for Ebola virus, and the second tier testing, which might occur later in the day or the next day, will be for malaria and also for flu and COVID-19 using their real-time PCR test. DCLS is providing both Ebola and COVID-19 kits to the Ebola assessment and treatment hospitals and those in the Dulles rotation for testing. Acceptable specimens include a purple top blood tube for Ebola and an MP swab and viral transport media for the flu and COVID-19 testing. The DCLS test request form is required and should be sent along with the samples. Next slide, please. For facilities who are caring for a PUI, the person should be isolated in a single room with a private bathroom and the door closed. The number of personnel who enter the room should be limited, and a log of people entering the patient's room should be maintained. Visitors should also be limited, and the facility will need to have procedures for monitoring and managing visitors. Aerosol generating procedures should be avoided, and CDC guidelines for cleaning, disinfection, and managing waste should be followed. Standard contact and droplet precautions are recommended. The specific type of PPE depends on whether the patient has vomiting, diarrhea, or bleeding, and whether the patient is clinically stable or not. In addition, the facility should consider use of PPE as appropriate for COVID-19. Next slide, please. This slide is just a reminder that with the 2014-2016 Ebola outbreak in West Africa, there was a lot of attention and money and resources going to prepare U.S. healthcare facilities for Ebola. A national framework was established, and this recognized that all U.S. acute healthcare facilities have an important role in preparing for and responding to Ebola, but the roles and responsibilities differ by facility type. Within the framework, there are three main tiers. First is the frontline healthcare facilities that could identify, triage, and isolate possible Ebola patients. Second are the assessment facilities that could receive and isolate a PUI and coordinate Ebola testing. There were 6 of those identified in Virginia during the previous outbreak. And the third are the treatment facilities that could care for and manage a patient throughout the disease process. And 2 were identified in Virginia. Next slide, please. In terms of some key communications about the situation that have already occurred or are being planned, yesterday, the Virginia Hospital and Healthcare Association hosted a call with our treatment and assessment facilities and the hospitals in the Dulles rotation that evaluate travelers who are ill at the airport. We gave them an overview of where we're at and asked for their support and let them know that DCLS will be sending testing kits for Ebola and the COVID-19 and flu testing. In yesterday's clinician letter, we included a brief update about this topic. We are planning a webinar with VHHA in the next 1 to 2 weeks for all frontline hospitals, and we'll be reinforcing the importance of collecting a thorough travel history during triage. Next slide, please. There are a number of details we are still trying to work out. We know that CDC has developed guidance for health departments, and we're expecting that to receive that very soon, likely this weekend. This guidance will affect our resources, so we will work as quickly as possible to get those resources updated. Another thing we're looking into is whether or not we can compile Virginia care kits that could be handed out at Dulles. These would include things like a thermometer, hand sanitizer, and potentially an at-home COVID-19 test. Because for international travelers returning, they are advised to get tested for COVID-19 3 to 5 days after travel. Next slide, please. This slide lists some key resources that are available in the disease control manual in the Ebola chapter. We have a PUI form, which we will need to update after CDC releases their guidance. We also have a guidance document on managing a suspected or confirmed case of Ebola in their contacts, a daily monitoring log, a checklist for health districts evaluating a PUI, an evaluation algorithm for hospitals, a notification algorithm, and VDH talking points. I'm going to talk about some of these in more detail right now. Next slide, please. This is a screenshot of our one-page evaluation algorithm for hospitals, and it was developed in 2019 and is also posted on the external site. It walks the healthcare providers through the steps of asking about the person's travel history, potential exposures, and current symptoms, and then directs the user to the appropriate next steps, including infection control measures, PPE selection, and notifications. Next slide, please. This is a screenshot of our one-page checklist for districts when they are evaluating a PUI. It breaks down the process into key steps, provides hyperlinks to additional information if needed, and also tries to delineate who is doing what at the district and central office levels. Next slide, please. This is our 2-page Ebola notification algorithm that is for internal use only. It was developed in 2019. The first page covers which internal and external partners should be notified at various stages of evaluating and testing a PUI. The second page contains key contact information at VDH and at our treatment or assessment facilities. And this will need to be updated very soon because there have been some turnover for the folks involved. Next slide, please. This is a screenshot of the Division of Surveillance and Investigations public-facing Ebola webpage. We updated this this week to summarize the 2 current outbreaks and to introduce traveler monitoring in Virginia. On this page, we link to the VDH fact sheet, which is also updated this week, and lists key resources for healthcare providers, including the evaluation algorithm for hospitals, DCLS testing and shipping instructions, and another page where additional resources for healthcare providers are located. Next slide, please. We understand that the health districts are swamped with COVID-19 and that this is adding a lot of work to your plate. We will be sending out a survey next week to assess districts' capacity to conduct traveler monitoring. As mentioned earlier, monitoring is expected to occur 7 days a week. We are looking to stand up a small team in the central office that can assist local health departments with monitoring. However, our preference is that for the local health departments to conduct the initial interview to ensure they have a good relationship with that individual should that person become symptomatic. We have asked CDC about the possibility of using COVID-19 funded staff to assist with traveler assessment and monitoring and are awaiting a response. We hope to have more information on this by next Tuesday. Next slide, please. We do plan to provide our next update at the fireside chat on Tuesday afternoon. And with that, I will turn it back over to James. Thank you.
Thank you all. At this point, we'll have questions and answers in the chat. If you've joined the meeting by WebEx, please type any questions for presenters in the chat box. If you've joined the meeting by phone, please email your questions to donald.moore@vdh.virginia.gov with the subject line LHD call question. Just as a reminder, at the end of your presentation that was sent out this morning, it includes the PH Ops updates. So you do have those to review, but like I said, they're not going to be presented today. With that, we'll go ahead and mute the call. Continue putting your questions in the chat box. We'll leave it open until I see a slow in the questions and the answers coming through. And at that time, we'll end the session. Thank you and have a great weekend.